Um, so thank you so much to everybody for being here today. I'm getting to know some of your names and faces over the Zoom blocks, so that's enjoyable for me. For those of you that have joined us previously, we're now in webinar number 6. For those of you that are here for the first time, perhaps because of this particular topic. Great to be with you. We are going to cover today between 12 and 1 caregiver mental health, adult mental health, and early childhood well-being, and really focus on, we're all in this work because of our work with young kids or kids in general. But how do we really equip the mental health workforce to have some supports and skills and resources for you all around both understanding the impact of adult wellness on very young kids and for you to understand or have some initial steps on what to do when that is a concern with the families that you're working with directly. So thank you for being here. We're recording partially because we all have webinars that we intend to sign up for, and then the day takes it upon itself to not allow us to be at our computer during that time or they're attending to something else. So this will be disseminated for that reason, and we'll just disseminate the slides and any resources discussed as well. Thank you. I don't think Haley is with us today. She has been previously, but just thank you to Haley and the Building Stronger Foundations team for partnering with me in this work. It's been a true honor to get to spend some time with you all over the course of now the past 6 lunch hours, and we have 6 more to go. So we're officially at our sort of midway point. But just to delve into sort of the range of topics that relate to the sort of field of infant and early childhood mental health. All of them are here. So we started with the foundation, walked through kind of understanding attachment and relationships. How do we reframe or understand differently behavior in very young kids that feels challenging? We talked through the sort of the lens of trauma and toxic stress. 2 weeks ago, on April 1st, we focused on reflective practice for adults. And that really crossed both, adults as caregivers and parents, and families, and as well as the workforce. And then today we're going to get into specifically caregiver mental health. I will say a lot of the sort of focus of or examples around this particular lecture today are going to focus on maternal and sort of perinatal postpartum depression, because there is a sort of a lot of relevant sort of research and resources around that specifically. B, also because that is something that is so relevant and close to sort of the work of very young kids. And so something sort of worth examining specifically. And C, because it's always good to have 3 reasons for something, because next time we meet, which will be a month from now on May 13th, we're going to focus specifically on supporting fathers and grand-led families. So there'll be lots of sort of fatherhood examples in that. Then we'll talk about developmental differences and sort of, how and when to screen and intervene and support, and what that work looks like in partnership with families. Relationship and early care settings will be 9, and we'll do a few more that get us through August. So thanks for the opportunity to sort of go through all this content with you. And for those of you that don't know me or haven't been to one of these before, my name is Kate. I am a clinical social worker by training and part of the faculty at UConn School of Social Work. As I said, through contract under the Building Better Foundations grant, we have the opportunity to partner with the team that you're all engaged with in Ohio. And a lot of my work has been in a range of community settings, supporting always sort of, kids 5 and under and their families, and also importantly, the workforce that supports them. So teachers, primary care providers, et cetera. Our goal for the next hour, so at large, it's, as we said, sort of really focusing on sort of understanding adult mental health, caregiver mental health, parent mental health. We'll use all those words interchangeably to be inclusive and considerate of the many different roles, but sort of how adults are doing with respect to their own regulation of mental health and the impact that that has on the behavior and well-being of infants, toddlers, and young kids. So our goal is to accomplish the objectives that you see on the right side of the slide. So for you to understand and be able to describe common perinatal and caregiver mental health challenges. So thinking about, the impact of and sort of how that shows up in parenting, and the potential impact of those mental health challenges on their very young kids, recognizing the signs and risk factors of caregiver mental health concerns, including how many of these show up in caregiver and child interactions, because that's sort of our port of entry, right? To explain how caregiver mental health influences attachment regulation and early relational health. And then what do we do about it, right? So the important thing is, for us to sort of have an understanding of like the size of the problem, how to identify it, how it impacts very young kids. And then the fourth objective of just, what are relationship-based trauma-informed strategies to respond to caregivers with empathy, reduce their stigma, and support connection. It's not always sort of on the work of us necessarily within our roles to sort of take on a therapeutic relationship with that parent, but how, or caregiver, adult, et cetera. But how can we use our relationship with them to give them support, help them with sort of additional steps into their own services if indicated and appropriate, and just acknowledge that, focusing on their well-being is as important as giving them strategies around their child, because both of those things have to be in place for the work on behalf of their kid to happen. So hopefully that's what you all expected to hang out and do together today. And I will just check the waiting room one more time before we continue on. I think we're good. These are sort of foundational slides that are in all of these talks, again, for both any of you that are joining, any of these lectures and haven't been to the earlier webinars, and or just to kind of ground us, right? So that any of these topics, we want to sort of focus on the principles of infant and early childhood mental health, which are that relationships are central, that development happens within context, right? So kids don't develop on their own. They're not potted plants, right? They're developing in the context of their family, their culture, their home life, their neighborhood, their school environment, et cetera, and sort of the give and take of that, and that all of this work is really strengths-based and prevention focused. And each of those three bullets applies so deeply to this topic as well, right? This idea of, the how and the why of parental or caregiver mental health. Okay, so the other side that we have consistently here is just this slide to define mental health in early childhood. So in our society, most of the time there is acknowledged stigma around mental health, and we think about mental health when it's poor, right? Whereas we think about physical health in a range of ways, many of them preventative and sort of health giving. We tend to only think about mental health when it's, diagnosable or concerning. And this is a much more sort of, again, strengths-based, relationship-based, and developmentally anchored definition for infant and early child mental health. It's the developing capacity between the ages of birth to 5 to do three things. So to form close relationships, to experience, tolerate, and express a range of emotions without lasting collapse, and to explore the environment and learn. And so many of those things are peppered by how our adults are doing, right? And so with that, we move on to the content. So understanding and addressing caregiver mental health and its impact on early childhood. So you can see here, the baby's crying and the dad looks like he's crying and the mom looks like she's about to cry, right? And so, kind of that dance you can't select one of these individuals and pull them out and work on how they're doing separately. It's really about, the mix, because so much of caregiver stress is around the child. And so it becomes very intertangled, and therefore an opportunity to intervene in that way. Rather than individually, which unfortunately is the way that much of our medical system sees people, as sort of individuals that live on their own. Um, so instead, we're going to spend a little bit of time on the argument for focusing on adults when we're there for the kids, and how that's actually beneficial. And in many of the interventions that we offer, we talked about this a lot last time with respect to just adult regulation, because that's such a key sort of component of child well-being and child regulation. For the kids that they can absolutely be the name on our file. They can absolutely be sort of the way that we get in the room. But that, we don't have the benefit of only working with them because that's not effective, right? That we need to sort of really think about what are our ports of entry to kind of see and experience and understand the adults, and to support them as well. And that I hope if you walk away with anything from this hour, it's that, even though we're there for the kids, it's not being nosy and it's not below or above your pay grade to inquire, discuss about sort of adult well-being as well. And so hopefully you'll walk away from this hour, and happy to follow up with any of you or share additional resources. There's a ton of really good guidance out there around how to have these conversations when it's clear that the adults that we're working with are not doing really well. And whatever role you're in, whether it be family navigation, early intervention, education, et cetera, so much of our work is either adult partnered or adult dependent, right? And so we tend to sort of feel like we're choosing a focus when we get our degree and go into these sort of silos of the work, but that really anything early childhood has to be adult focused too. Um, you may have seen this slide before, and all of this is from the book Neurons to Neighborhoods, which now is about 30 years old, which is pretty wild. But that is a book that was really sort of pivotal in its time to sort of really link the impact. It was when a lot of the brain science was sort of first emerging, as it relates to sort of mental health and development. A lot of that work really sort of solidified or made important, the work in early childhood, that we're not just sort of playing with toys or coloring on paper, but that, that this work is as sort of equally important to the neurons and sort of the brain development of young kids as any other domain of intervention. But the the book itself really helped solidify both the environment and the relationships as being so key to how the opportunity that babies have to develop, solidified by, what's seen in their brains. But what we know is that babies and children grow and thrive in the context of dependable relationships. And dependable is, everything that you think comes with that word. So the more sort of consistent and predictable that relationship will be, the more the child will thrive and grow, right? That without such at least one relationship, the development is just disrupted and consequences can be severe and long lasting. So, the kids that show up with real difficulty with regulating and sort of the tasks of a kindergartner or a first grader, often if you look at where their stability was within relationships, within certain key parts of when their brain was developing, you can see sort of where that math comes in clear. And therefore, like, how can we sort of scaffold that back so that we're helping them be successful in these tasks and not just giving them additional tasks that they don't have the capacity for. That nurturing and responsive relationships build healthy brain architecture and provide a strong foundation for learning, behavior, and health. So, the flashcards around, numbers and letters and sort of all of the academic stuff is great, but really, nurturing and responsive interactions with a caregiver is going to be much more stimulating for brain growth and for a child to sort of learn naturally language and all of those sorts of things just from their environment. So both are good, but nurturing and responsive interactions are far more important. And that when protective relationships are not provided, that's where you see more of the trauma results that we talked about in our webinar last time. So when we think about the term attachment, and this is something that you guys are probably all familiar with, but just wanted to give us a grounding as we then apply this to to adult well-being. Um, uh, Sorry, I'm letting somebody in the waiting room. The key relationships are sort of what naturally builds human babies and young kids and older kids are naturally and biologically primed to uh, pull in close relationships to really sort of define their meaning making of a situation based on sort of how that adult is doing, right? So the natural cues to kind of read mom or dad or grandmom's face or response when we hear a loud noise, right? That like they're naturally cued into all those things. And so everything happens within the context of those relationships, right? So but when you see the bullet there, affects internal working model, that is a very intimate, healthy language. But what that means is like the patterns of behavior of, if I drop a spoon, mom is going to pick it up for me, or if I cry, I will or won't get a response. Is sort of the meaning making behind a working model. Like how do I as a human in this world sort of understand predictable interactions, and then that applies to other relationships, right? But those are sort of first laid in the dynamic that a baby or a toddler has with their key caregivers, their consistent caregivers. And then all of that shows up, in an individual child in kindergarten, right? So by the end of preschool, so by the time a child is 4 or 5, and they're walking into a kindergarten classroom with a heavy backpack on a September morning, right? They're asked to do the whole list here, and it looks exhaustive because it is, right? So direct attention away from stressful triggers, anticipate another person's emotions, talk comfortably about their own emotions. So, are you happy today? Are you sad today? It's raining, etc. Like, how do you feel about that? They're asked to do that regularly, to use emotions to negotiate social interactions, both with peers and adults, to use language to communicate their feelings, to use strategies to prevent being overwhelmed, to stop from expressing inappropriate emotions, to stop from exhibiting inappropriate emotional behavior, and comfort him or herself independently, to approach or withdraw from situations, to use play to deal with difficult challenges. The list is going on. But these are all tasks that kids are asked to do regularly within their kindergarten setting, and all of those are sort of onboarded or taught by the adults that they were with before that time, right? So again, just sort of another argument for how the families that we're working with are doing in a sort of routine and interactive way, really sort of feeds into a child's opportunity to learn these things, to practice these things, to sort of build their own pathways on these tasks, uh, before they're asked to do so when they're the smallest ones in the building in kindergarten. Uh, and that a lot of this is really around, adults or caregivers facilitating regulation, right? So when you think about the definition of infant and early childhood mental health, the definition said like the developing capacity between birth and age 5. So a lot of this goes from like very co-regulation dependent to, that task being less on the adult and sort of more on the child by the time they're 5. So when they're sort of ending that trajectory, if they're on a normal sort of mental health and developmental trajectory. So there's always caveats to that work, right? But knowing that like all of those things are really sort of facilitated by adult regulation. We need adults and caregivers to be empathic in the moment, like so regulate themselves. You can have your inner monologue, but how do we really understand where very young kids are in the moment? And sort of have these things that you see here practice. So discuss feelings regularly, model, management of feeling upset or bored or sad, right? Managing and having manageable and predictable and consistent routines with kids, that really sort of builds their stability and sense of independence in the world. Their own self-efficacy as parents. I can manage this. I have the capacity to, do the many tasks of caring for 2-month-old or a 2-year old or a 12-year-old in a given day. The confidence in the parent-child relationship, and those two bullets are often very interrelated for sure. But when I was doing clinical work at the University of Maryland, I would often get families that would say, like, it wasn't like this with her older brother, right? Or, some sort of statement like that, like letting them know that they have higher parental self-efficacy across the board in their family, but that there's a lot of conflict or a lack of confidence in their relationship with this particular child. And there could be a range of reasons why. Uh, and all of that is really dependent on the parent's ability to manage their own emotions. And we know that none of that is done perfectly in any given moment in time, but on the balance, are they able to, manage their own emotions, whether it be about the milk that's spilled on the floor or, the very adult things that happen before then. But are they able to kind of, be the bigger, stronger, wiser, kinder, as, Circle Security says, adult and, put their lid on and meet the needs of the child in front of them. Um, Whether it be a very big emotion that they're having or just sort of meeting their emotional state. So are they excited about something and are you able to say, that is so great that got the block over the hill or whatever it might be. So again, all those things are so adult dependent. And I just referenced Circle Security, and I know a couple of you on the call are able to offer this within the community, which is so great. But Circle Security is a group-based model. It's an international group-based offering that really focuses on supporting adults to learn the importance of sort of their response within a infant or toddler or preschooler's day. They talk about, the adult being the secure base and the safe haven, which is the hands you see on the left. And that they really have to be like the regulated other to match how their child comes back. So that you both have to give signals that it's safe for their child to explore, and this could be, the home itself. This could be the playground. This could be the classroom. This could be the book, right? That you can interact with this book in whatever way you want, including turning it upside down, so not being sort of rigid in the signals that you're giving a child about the activity that they're about to engage in, to watch over them, to help them, to enjoy with them, and then to meet them when they come back. In to sort of check in with you with their secure base in whatever way that they need. So is it, protecting them? Is it, being excited with them? And all of that, has to do with adults being, again, able to regulate themselves. And so as you sort of think about this circle, just wanting you to give you an opportunity to think about, how parental stress, mental health, substance use disorders might impact the response, right? That you might have the intention to kind of, you know, um, let your child, have the cues that this is totally safe and you're free and competent to explore however you want. You can delighting in your play. This is a wonderful moment, and I'm going to meet you when you come back, whether it's to soothe you, to comfort you, to celebrate with you. That all of that can be the intention can be there, but the adult's ability to do that in the moment might be clouded or limited by any of those things, their degree of parental stress, their degree of mental health concerns symptoms, and or their substance use that, again, just might make them any range of responses. And we're going to talk about how those things often come up in parental responses. But when parents' brains are stressed, and I think you saw this from the trauma slides as well if you joined us for that lecture. But just to give you a sense of, again, the intention can be there, but when there's chronic stress, there's inadequate sleep, often poor nutrition, emotional distress that causes an increase in stress hormones in the brain, which decrease regulation. So not only might I feel so more scattered, but if there's higher stress hormones and I don't have as much of an ability to regulate my body, because the stress hormones are designed to help us run quickly from a bear, respond to stress, which is to, have all of the things that make us sort of more physically capable to do that, which none of which are sort of chill and regulated. Um, and so when you are sort of at sort of more of a stress response place, both because of whatever might be worrying you, and also sort of your brain's response to those realities, our ability to do all the things that you see in the lower left corner, to attend to a task, to perceive, how your child is doing. We often sort of miss sort of short or smaller cues when our perception is down. Short-term memory goes down, right? Our ability to kind of learn, our ability to sort of find the words that we're thinking of and sort of have communicate clearly goes down as well. All those things are needed for parenting of young kids, right? And so this impacts sort of how we're showing up. And this graphic, I apologize, when I put it on the side, it became a little grainy and not as clear as I had wanted it to. It's from a book that is published by Daniel Siegel, or written by Daniel Siegel, who does a lot of work. He calls himself an interpersonal neurobiologist. So the idea of neurobiology, so brain development and interpersonal connections, how they sort of relate. But he talks about this as an example of parents needing to pause, self-regulate, and intentionally react to their triggering child differently, right? So instead of command and demand, it says on the top. So why did you do this? I want you to clean up your room, X, Y, or Z. Try to connect and redirect, right? So what about this was hard? It seems like you're upset. What about this was hard? How can I help you? Right. So the all of that is both knowing a different way to respond, right? Having the intention to respond in that different way, and having the ability to regulate yourself in the moment to, maybe have that spike in, oh, why did, we practiced this, like gave clear instructions, like, why did this not work? Like that can be an internal reaction. But how do we sort of stop that trigger and say, I'm going to take a deep breath and try to connect and redirect instead of command and demand, right? So it's a cognitive choice that has to be made in the moment, which requires, again, so which is why so many of the impacts of parental stress or parental mental health concerns are not about the lack of intentionality, but it's the lack of their ability in the moment to choose that different response or that different interaction. And we know that, that the early engagement is super important. So this is from a couple of different studies looking at population levels of children's health and well-being and literacy, and looking at sort of you see in the middle column, it's parents that were scored as more engaged, and on the right-hand column, parents that were scored as less engaged, so like less engaged with their child. And if you look at words heard per hour, right, it's 2,168 versus 616. So, and it's not even, they're not looking at different words, but just number of words per hour. So you could say this, it doesn't have to be like, reading the dictionary and different vocabulary, but just the number of words, the number of sort of vocal interactions between an engaged parent and a child versus a less engaged parent is significant. Words known by age 3, you can see sort of a direct correlation in sort of the child's like word recognition. Again, this is typically developing kids, so we're not looking at, indications of some child conditions that would impact this, but just, in their ability to sort of engage. Words heard by age 4. So 45 million versus 13 million. I don't know what graduate student counted all those, but we thank them. Letters of the alphabet that are recognized by 5, which is again like something that is considered, a kindergarten readiness sort of assessment. 22 out of the 25 letters from more engaged parents, and only 9 from the less engaged parents. So you're seeing this sort of begin to sort of delve into two different trajectories within school very early. And then parents read every day, so 59% versus 36. So again, like this idea of it's not just good, but we're seeing sort of true impact on the child's ability to engage in sort of the academic and social tasks that they're asked to within their very very early learning trajectory within school. Um, and when we think about, focusing, as I said, sort of specifically on maternal sort of postpartum depression, partially because A, as I said, it's so close to the sort of field and work of infancy and early childhood, and B, because there's a lot of really great data around it. Um, Wanting you to know a couple of things that we know from many, many different studies and published journal articles, but that it's a significant risk factor affecting the well-being of school readiness for young children, right? So often depression will show up in sort of characteristics of withdrawal. Like you can be in the room, but not as engaged or not as sort of you know interactive with your child. And we know that those moments of interaction are what really sort of facilitates and supports sort of brain stimulation for the child. There have been a lot of studies on mothers and families that are deemed low income or within poverty levels within this country, and that there are higher levels of depression, often with a combination of other risk factors at play. I will give the caveat as well that part of that is often because those populations are easy to study because you can work with a Head Start, right, that is sort of directly serving those systems. And so we know that there's higher endorsement of depression symptoms within those families. And part of it also is because we don't do as much public health investigation in families where there is more resources, that they're often in sort of private schools or places, and there's just not the same ability to sort of have those public health studies. So wanting to encourage people to sort of know that yes, there is often higher parental stress within those complex situations, and we should think about the presence of anxiety and depression showing up in every neighborhood, agnostic of the family sort of situation. But a little bit more about perinatal depression and that is a term that refers to depression relating to childbearing. So not happening just postpartum, meaning post-delivery, but this can happen during the pregnancy as well. So just looking at sort of the whole cycle of pregnancy and early parenting, and when are we seeing increases in depression? Part of that we know is driven by the significant life change and sort of additional new stresses, and also the hormonal changes which can contribute to this. But it's the number one complication of childbirth, which when you say it like that makes it clear that we should talk about it so much more than we really do. But after childbirth, depression is the second major reason for US women to be hospitalized. Again, we don't really talk about it in that way. But for those two reasons, it should be, really kind of universally assessed and discussed and screened for, and there should be much more supports around it. Uh, in general, there's considered, sort of a range of how this shows up. So, postpartum blues, as I think is a little bit of an older term, but is still used in some circles, is sort of really looking at like a brief dip in mood, typically within 10 days of giving birth. That is endorsed by anywhere between 50 to 80% of all mothers. So part of that is, again, you're not getting a ton of sleep during that time. You're going through body changes both physically and hormonally. And so that's sort of seen as sort of typical and not super concerning. And then, postpartum depression and anxiety is its own sort of category that we'll talk about in the next couple of slides. And then postpartum psychosis is often sort of the most talked about because it's the thing that gets on, the Dateline and the nighttime news, sort of those stories where you can see significant impairment in an adult, and often significant concern to their ability to care for their children or child, but that has a very low estimate incidence, right? So between 1.1 and 4 cases per thousand deliveries. So again, postpartum blues is very, very common. Postpartum psychosis is very, very uncommon. Perinatal depression at large, much more common than discussed. Um, So a little bit more just about like how it's showing up. So there are rates of depression among pregnant and postpartum women, depending on the study, is anywhere between 8 to 20%. And as I said, a couple of the studies that look specifically at early Head Start or Head Start moms, teen moms at a community pediatric health center, and women participating in a welfare to work program at a couple of different states give those sort of higher endorsements than that. So we know there's, but any of these numbers show that it's a significant thing to be considered. And how this specifically impacts parenting. I'll read this quote for you here. But much as she loved her child, a depressed mother is often emotionally and physically unavailable to him, since an infant's brain development relies heavily on two things: experiences and interaction with an attentive, responsive caregiver. The absence of an engaged mother is a critical loss. And again, as I said, when we think about depression, it can certainly show up in dads, in sort of other traditional and non-traditional caregivers as well, but a lot of the data is around postpartum depression in moms. So just want to give that caveat. But that, children, there's often sort of less stimulation in these environments, and we see the impacting both, again, the sort of the words and sort of literacy of a child, as we saw on that one side, but also just the regulation and sort of patterns of interaction for a very young child. Researchers at Harvard's Center for the Developing Child have made claims that these are kids that are not only at risk of neglect, so their needs not being met, but sometimes physical abuse as well, because they're having to sort of be more demanding for interactions. Often you see like a bifurcation in responses, and this can be either adults can either go one of two ways or both sometimes. They can either sort of be the more typically like disengaged or withdrawn. So parents that it's a heavy lift for them to play and interact and be cheerful and sort of, those things. You can also see it show up in the sort of more hostile or intrusive, right? So that, and this can look like the anger, the quick to sort of anger, the sort of shorter fuse, right? And both of those can be symptoms of depression in a caregiver. So, when we're thinking about, how kids learn around through patterns, we know from some of the attachment data that we went through at the first interaction, or sorry, the second webinar rather, that it's easier for kids to make meaning of something if it's consistent. So if it's very hostile and intrusive, they sort of learn quickly, like it's not worth engaging him or her, and I'm going to figure this out myself. If it's more disengaged or withdrawn frequently, then you'll see kids that like understand that they kind of have to really make significant attempts for attention, but that often sort of wins over. When it's sort of not consistent between the two and sometimes hostile and sometimes disengaged, that's when it can be most confusing for kids to sort of make meaning of how do I learn about how to get help or sort of get support from my caregiver. This is, again, oops. I want to play this clip for you in just a minute, but I will prime it up for you. So Down Came the Rain was a book written and published by Brooke Shields, who was a famous actress. And she came out in the early 2000s to share her postpartum depression story. She was on Oprah. She actually dealt with backlash from Tom Cruise because he didn't believe in the treatment that she got around it, but really did a lot to really, through sharing her own story, elevate the experience of maternal depression. And so I'll play for you this clip here just to give you a sense of her own words about it.
I suffered acutely from postpartum depression. And the biggest tragedy of all of this was that I did not know that I had postpartum depression. I did know that I wanted to die. I did know that I was incapable of holding or looking at or kissing or smelling or singing to my perfect tiny little baby. I just couldn't fathom that I would have something called postpartum depression. It just wasn't going to happen to me because I wasn't going to be that person. It was ridiculous. I did know that if I stayed too close to my baby, that I would start to feel weak in the knees and I would start to get dizzy and start to faint. I knew that I cried all the time. Still didn't know I had postpartum depression. I knew that I was beginning to seriously plan ways that I could disappear quietly but permanently. What I did not know was the very thing that could have spared me and my entire family irreparable damage and deep, deep misery. So in my mind, all I could think of was that I was a bad mother, and my daughter and my husband and everybody around me would have just been better off without me. And it was very clear and rational. It wasn't dramatic. It was just the best thing for me to do would be to leave. I had made a huge and horrible mistake. I was an incapable mother, and I needed to just disappear. I remember going to my doctor for one of our first early visits, and he said, how are you doing? And I looked him in the eye and I said, I can't do this. I really can't do this. I made a horrible mistake. I don't think she can be taken back. But I can't take her home. She really can't stay with me. And I've changed my mind, and it would really be better if I just didn't have to do this. So just help me not do this, please. And he said, oh, you know what, it's fine. You'll be fine. My wife went through the same thing. It's the baby blues. You'll be, you know what, it's hormones. You'll be fine. You'll be done very soon. I was told not to worry, that it was just going to pass. So we've read the stories about what happens when postpartum is left unacknowledged. And it is a fact that more than not, it worsens before it gets better. Lives, it is a guarantee, will be saved by having this bill passed. The Mother's Act is something that we've been deserving of and waiting for a very long time, and families will be spared because we're all touched by it. And the devastating effects of it last a long time, even beyond the immediate trauma that you experience in the home. And I really believe that postpartum has a huge range and a very, very, very long reach. And awareness needs to be raised. The stigma of it needs to be lifted so that women can feel not ashamed that they are not the epitome of the blissful, perfect mother, because they are experiencing a severe disease that needs attention.
I want to stop sharing slides for just a minute. If anyone has a reflection or response to that, to share either in the chat or go off mute. Okay, I won't make people do so if it feels heavy right now. It's just I can't imagine the incredible bravery and sort of meaning of her doing that and the number of women that it takes that were able to see that and see themselves in it and feel supported. Elizabeth, you went off of mute?
Yeah, I just I mentioned in there, but my little guy is just over 5 months, and that was really powerful to hear because a lot of people don't talk about it. So that was way before I had babies, but it would be really cool
Yeah,
to hear now, or it was really nice to hear now because it's hard. It is hard.
yeah,
So
yeah.
that was very impactful.
Very impactful. And that she went to her doctor and said, I can't do this. And he says, no, you can. And again, like the well-intended response, right? But the lack of discussing it, really sort of doesn't norm the sort of supports around it, right? She's so brave and courageous to share her story. I appreciate her using her platform to raise awareness. Yeah. We need to remove the stigma. There is already enough about being a good mom. So how could someone utter that they don't connect with their baby? We need to help everyone, right? And so for so many of you, like if the moments that you're interacting with families, it might be the brightest part of their day, right? So it might like they might kind of like rally to, Miss Jen's coming. I'm gonna, put my bravest face on because they want to sort of show up in a different way. And so I think the importance of like not not waiting for adults. If there is a concern, not waiting for adults to the other adult to mention it, but just sort of, norm the conversations around parental stress, around, what that's like for you, et cetera. We're gonna spend the last couple of minutes of this hour kind of talking through what to do when that shows up for you stuff. Um, Okay. Again, this is just sort of more impact on maternal depression and a child's development. I think we've made that case. Um, so, the Affordable Care Act mandates depression screening for new moms by the American Academy of Pediatrics. They're asked to do so many things in a, up to 20-minute well visit for kids. So sometimes this happens routinely, sometimes it doesn't. And so, really kind of seeing yourselves as extenders of these sort of initial opportunities to either do a formal screening or have discussions, I think is really important. And often, I think one of the things that's important for us to sort of consider, again, our work is with young kids or kids in general, right? But is really around this idea that, a parent's stressor and a parent's motivator is often the same small package, like their kid. So they're going to show up in places for their kid that they don't go for themselves, right? So they might not be going to their own primary care. They might not be sort of doing all of the things, seeking behavioral support for themselves, but they will for their kids. And so how do we kind of, not assume that they're getting supports, but, have these discussions with them and wanting you to know a little bit about what some of the common sort of measures or screeners are. So the Edinburgh or the EPDS for postpartum depression is typically used during pregnancy and up to 1 year after. And that is, a clinical assessment of postpartum depression specifically. The PHQ, so or patient health questionnaire, 2 and the GAD 2 are considered, and 9 and 7, so they're different versions of the same screeners, are considered good sort of like brief questions. So the 2 and the 9 and 7 indicate the number of questions in each. So they're considered something that you could do like within an intake, within an interview, um, that look at sort of endorsements of of symptoms of both depression and anxiety. There's a PTSD checklist within the DSM, and then most sort of specific to parenting that goes beyond the 1 year limit of the Edinburgh is the Parent Stress Index. There's a version 4, which is the short form. And wanting to just sort of give you the opportunity to see some of the questions here. So it's a Likert scale response. So the MA is like majorly agree, not sure is 3, so sort of like a neutral. 4 is disagree, and then 5 is majorly disagree. And so you can see, like, I often feel like I cannot handle situations very well, caught up with the responsibilities of being a parent. Since having my son, I find that I almost never get to do things I wish I could do. I'm not happy with the clothes I bought last time. So you can see there's a range of questions. Some of them are sort of very normed to just sort of parenting tasks, and some of them are just sort of more broadly about sort of how they're doing. On number 13, my son rarely does things that make me feel good. So I would disagree with that. I would majorly disagree with that. I would sometimes agree with that, And like any good screener, I think the important thing that this does is really allow for a conversation around it, in which we can do 2 things. We can norm some things, that, all parents feel like, especially in these early months, like you're giving way more than you're getting, or sort of, some of those types of conversations, but just getting a sense of sort of where that is. If you do a formal screener, so a screener is just screening for something, right? So it's not a diagnostic, it's not giving but it's just indicating that another step towards exploring supports would be indicated. So if someone scores high on either the Parent Stress Index or the Edinburgh, it doesn't mean that from that, have a diagnosis of depression, but that there was a correlation between if they were referred to their own clinicians, there's an up to 40% chance that they would meet criteria for diagnosis based on that assessment and interview. And that, really what you want to do is sort of have a conversation to validate feelings. Any of the things that you would have wanted to say to Brooke Shields as she described how she was feeling in those moments, right? That she's not alone, that this is actually very common within early parenting and sort of post-delivery experiences. That make sure that there's a plan for follow-up. And that could be just that you're gonna call and check in on her in 2 days, right? That could be that, if her feelings of withdrawal or whatever get worse, that she has sort of people in her life that she can reach out to, whether it's, people within her church, people within her family, in her neighborhood, et cetera. And, just have some of those conversations. And often, one of the things that some of the mental health folks say so often is that you don't have to be a therapist to be therapeutic, right? And so much of this is just in those supportive really conversations around this is really stressful, and what would it be like for you to ask your mom to stay over for a night so that you can get some good sleep, or like this, it doesn't have to be sort of no intervention versus only clinical intervention is what I'm trying to say here. So much of this is really around what are the parts about the our work with a family when something like this is present, that we can have it be focused on their role as parents, but just offer some support and some conversation, so that it's not just something held within their own head, it's shared with somebody else, right? And we're going to close with just, some key core principles around knowing that the symptoms here are going to be either withdrawn or sort of irritability in a response to kids, and that kids need predictability and sort of more of a matching of their regulation. This is also from that book that I had the character around the choosing the adult response. So Daniel Siegel, No Drama Discipline is the name of the book. He talks about the themes of anchoring in adult regulation. So anything to sort of practice their own regulation or strategies to do that. Anything around routines would be helpful for both them and their kids. Anything to support, like picking some part of their day and having more sort of nurturing moments in there. A lot of this, comes into sort of how do we right set their expectations of tasks so that they're developmentally achievable for their child, right? So that they're expecting a 3-year-old or a 2-year-old or a 2-month-old to kind of be able to do the things that they would normally be able to do, and that a lot of times when an adult feels overwhelmed, they want the child, whether consciously or not, to be able to take on more, and that can lead to a lot of conflict. And that where are areas where kids can lead, right? So is it some sort of chosen play or task where they're sort of really planful around allowing the child to stir the Play-Doh or whatever it might be. Um, and a lot of it, is really comes down to helping them with, again, how do they want to be different in that moment? How do we help them sort of make that intentional shift in their mind of connecting and redirecting when they want to. So, the intentionality of using a calm voice, of not having their response to their child be more harmful to their lack of parenting self-efficacy, their lack of sort of feeling secure in the relationship and their role as a parent. But how do you kind of remind them of its intentionality around some of these strategies? And that reframing conflict is normal, especially in very young kids, and toddlers themselves can be very cute deliverers of a lot of conflict, right? And so some of this is norming it for them, that it's not about you not meeting your child's needs or whatever it might be, but how do we sort of meet this? What is a strategy that they're going to have on hand to respond to conflict between them and their child, so that it doesn't get harder, but it gets easier. Um, Wanting to, again, give parents information about their child's development, and support and emphasize um, uh, where those challenges exist, and giving them some strategies around them. Information about the impact on children of how they're doing, right? So that they really see that like helping themselves is not selfish. It's being a good parent. It's helping them meet their child's needs. And how do they sort of regularly understand and recognize their own stress? So is it a really simple like mood meter or something where they're sort of rating how they're doing that day, and checking in with themselves more regularly. Um, and Sorry, wanted to spend just a minute here, but helping remind caregivers that talking about their own feelings uh, is really supportive of their kids developing those skills, right? So if a mom or a dad is sad, to which you can feel it in the room, not talking about it is not going to be helpful, right? So giving them sort of age appropriate language to share with their child around, mom feels sad today too because we weren't able to do that, or we had this, visit planned and they weren't able to come. What can we do? What can we do to sort of help you and I both feel better, right? So those sort of easy conversations that are developmentally appropriate around acknowledging and responding to behavior and a mood is important. Um, and knowing that small changes matter, so it's not that we have to sort of solve, significant clinical concerns, but that moving the needle towards, more parenting self-efficacy, parents feeling not alone or lost in their role, that they have a partner, and that they're linked to supports when needed, is very meaningful. So thank you for the hour. I realize that that was quick and a lot of me talking at you about this topic, but if you have any questions, my email is right up there on the screen, and I will be sure to share the recording and the slides with Haley as well. Thanks, everyone.